Our final speaker this morning is Paula Doyle. Dr. Doyle came to the University of Rochester to complete her fellowship training and is now an assistant professor with the Department of Obstetrics and Gynecology and the Department of Urology. She is also Chief Medical Officer of EndoGlow, a surgical tool startup she co-founded. Her talk is titled Near-Infrared Imaging and Fluorescence in Surgery. Welcome, Dr. Doyle.
Okay, thank you.
I got it.
You got it?
Yeah.
That's okay. Great. Good morning. Thank you very much for coming. And today I'm going to be talking about near-infrared fluorescence in surgery. And I find it really interesting that I'm going to be talking to you about this because I was not one of those kids that at 5 years old knew that they wanted to be a doctor. I'm currently a reconstructive pelvic surgeon here at the university. But I took a little bit of a different life path, I guess you could say. I graduated from SUNY Albany with a degree in philosophy. And then I went to New York and I worked in the fashion industry for a while. It was kind of like The Devil Wears Prada, but not as bad as that. But it was bad enough that it drove me to the Peace Corps. And then I was in the Peace Corps in Papua New Guinea for a while in the highlands there. And that's really where I decided that I wanted to go into medicine. So when I came back, I did my prerequisites and I went to the medical school at the University of Texas. And then I stayed on and did my residency there. I came to Rochester for my fellowship. And it was in my fellowship that I really started to make these connections and relationships that exposed me to research in a real way for the first time. And it was those relationships that I developed that made me want to stay on as faculty after I graduated fellowship. So what I'm going to do today is I'm going to tell you a story about what it's like to be in the operating room. You get an idea of something you want to change or something you want to do, but how do you actually go about doing it? And what's the process behind it? But first, we're going to do a little bit of science. And so this is the light spectrum. And remember that light is just waves of energy, right? And on the left here, you have ultraviolet. And then on the far right, you have near-infrared. And near-infrared is what we're going to be talking about today. And then sort of in the middle left is the visible light spectrum. So things that we actually can see. So near-infrared, you cannot see with the naked eye. There's cameras that can see it for you, but you can't see it. Near-infrared is used a lot in surgery. It's used a lot in medicine. And the reason why it's used is because the light waves itself do not get absorbed by water. So what that means is it goes through blood, it goes through tissue, and allows, in this case, the surgeon to see about 1 centimeter through the blood, through the tissue, this type of thing. So that's why we use it a lot in medicine. One of the places we use it the most is robotic surgery. So I'm sure that you've all heard of robotic surgery. It's minimally invasive. And what you see on the left here is the console that the surgeon sits in to operate. On the right is the robot itself with all the arms. And then in the middle is what it looks like if the robot was set up over a patient in the operating room. So robotic surgery has a lot of advantages. The optics are really, really good. Your movements are very fluid and precise. But like operating in, say, a video game, you have no feeling. You can't feel the tissue. You can't feel what you're actually operating on. It's all done by visual. And this is part of the reason that the optics and the near-infrared are so important. One of the things that is also like a video game when operating robotically is the surgeon has superpowers. One of the superpowers is that the surgeon, just by clicking their fingers together, can switch back and forth between the visible light spectrum, which is what we all see, and then near-infrared. And what near-infrared looks like when you're operating, it's kind of like night vision goggles that the military uses. You've seen that, where everything's black and white except for the area of interest, which is this bright green color. So this is what we're going to be talking about. This is a picture from a robotic surgery. This is a patient of mine, 55 years old, 3 children, lives here in Pittsford, has had a previous hysterectomy done. And what we're looking at is the bladder. And the bladder is kind of stuck to the underlying connective tissue. And it's my job to peel the bladder off of the underlying connective tissue without making a hole in it, ideally. So I'm looking at this, and it's stuck. I can't really tell where the edge of the bladder is. I'm looking at the folds of it, and I'm thinking it could be here, right? Could be. It could also be here. It could also be up a little higher right there. So I'm going through this case just very slowly, very methodically, trying to dissect the bladder off. And I want you to know she's fine. Don't worry. Everything was okay. But I was late getting out of the OR, and I'm rushing to a research meeting. And I get to the research meeting, and I start, I'm sorry I'm late. This is why I was late, and telling them about this case that was going on. And I must have said to my research partners something like, I wish I had a flashlight I could have put in the vagina to just backlight the bladder so I could see better, or a glow stick, or something. And so we spent the rest of the research meeting kind of talking about ways that we could come up with an instrument that could provide backlighting in these types of situations. So this is ultimately what we came up with. This is a standard looking manipulator, but you see the green part on the end that looks like an egg? That glows, and that fluoresces under near-infrared imaging. It's an inherent property of the plastic we developed. So there's no batteries. You don't need to plug this in. All the surgeon needs to do is use the manipulator like they normally would, and then just toggle back and forth with their fingers between the full spectrum light and then the near-infrared light. We went through a lot of different iterations of the prototype, and we also had to work out things like sterilization. Can it be sterilized and still hold the fluorescence? These are the types of things that we did. And then we did a pilot study. Because we have this, we think it works, but we really need to make sure that it does what we think it's going to do. So we did a pilot study, and we actually found out, yes, it does fluoresce, and you can see about 1 centimeter worth of tissue through the tissue. But there was also things that came up in this pilot study that we didn't expect to find. These are unexpected findings. So one thing when we were operating robotically and using this device is that it allowed you to visually see relative tissue depth. Because remember, when operating robotically, you can't feel anything. You can't feel if the tissue is thin or thick. It's all based off of the optics and what you can see. And when we used this device and had the fluorescence on, you could see that. You could also see tissue quality. Was the scarring just at the surface, or did it go all the way down? Subsurface pathology was another thing. You've heard of endometriosis. Endometriosis can be all sorts of different places. It doesn't just sit on the top of the viscera. It goes deep. And so it allowed us to see things like that. Here's some other pictures, robotic case. This is with our device in the rectum, which is standard as well. But you can see that it worked. We were just happy to see that it worked. It could fluoresce, and you could go through the tissue. Oops. So relative tissue depth and tissue quality. This is a familiar picture to you because this is another stuck bladder. There are more stuck bladders out there than you would think. And so on the left is the visible light spectrum. This is what it looks like just normally. And then on the right is with the device inside the vagina, and when we switched to near infrared. And the place that has the most fluorescence is the area with the least amount of tissue. So we knew that that was the thinnest part. It also, because it's transilluminating the tissue, it allowed us to really see where the edge of the bladder was. And we could start our dissection with more confidence than without using the near-infrared. And with this, we could tell it was scarred, but we could see where it was scarred superficially or where it was truly scarred deeply. The next is subsurface pathology, which is a little bit more difficult to show pictures of from the operating room. So to demonstrate this, I chose apples. I'm assuming that you've all eaten apples, picked out apples from the grocery store. Very common thing. So looking at these apples, which one would you choose? Which one looks the best? And, bless you. If you would have chosen either one of them, you would have been missing that underneath the surface of the skin, they're bruised. These are near-infrared pictures of the apples. So if you were working at Wegmans and you were in charge of quality for the produce section and you just got a new shipment of apples in, you wouldn't just go down to the loading dock and look at it and say, yep, these are good. You would have taken your handheld near-infrared imager with you. It's standard. You can Google it. It's standard in agriculture. And you would have gone down and actually looked to see what the apples look like underneath the surface of the skin. So if it's standard in agriculture, why can't it be completely standard in surgery? Okay, so we did this pilot study. Now what do we do with this information? We're academics, so we want to present it at a conference, right? We want to tell our colleagues about it. But before we could do that, we needed to talk to UR Ventures. UR Ventures handles all of the intellectual property at the university. And so we went to them, and we ended up filing patents. And then we could present it nationally to our colleagues. And then what ended up happening is Endiglo is a spin-off company that is going to be making these devices or similar devices to get it out to other surgeons. Because I'm glad that it could help my patients and that it could help other patients at the university, but we really wanted to help patients, everywhere and not just locally. So that's what Endiglo is currently doing. That's it. Thank you very much. I appreciate it.